So we are on week 6. It's amazing. Time goes by very, very quickly, and we are halfway through. We've actually already done a review, 2 of them already for this exam, and they are already posted on your announcements. Remember when I put exam 2 review recordings, I will continue to edit it and update it and have all the reviews in one announcement. You're not going to get 6 of them. So just keep going back to that announcement and you will see them renewed. And when they're done, I'll say all recordings are here so that you know that they're already there. Right now you have 2 of them. I do mine tomorrow at 4 o'clock. And you know, I'm going to be having it up posted for you probably by 6 or 7 o'clock tomorrow night. You know, I'm pretty quick with putting that up. So try to get yourself to a review. They do help you. Again, not just my review, somebody else's. It gives you 2 views on the same information. And maybe between that, you're like, oh, I'm understanding what they're looking for. So we already did our quiz. We have NCLEX questions due, and there's another CJ Sims due. Now, when you were on your doing your quizzes, when you were finished, I've already updated and added your assignments. So thank you, Lisa. Your assignments have already been added onto your grade. I appreciate that. And actually, I've notified all of the pediatric courses just to be sure that everybody remembered. So thank you. Sometimes, you know, brain gets old, you don't remember everything all the time. And that's okay, because I have all of you to help me. So we're going to be going into our PowerPoint. It's hematological, immunological, and then some cancer stuff that we're going to be going over too. So hematological, immunological dysfunction, when we talk about that, it's all about stuff about the blood, isn't it? It's all about what's in the blood and how does it help us. So when we're talking about this, how do we look at it? How do we evaluate it? Well, number one, you're going to have a child who's going to give you some symptoms. Many of the times, what you'll see as a symptom is a child who is tired, lack of energy. You know, they're not the way that they should be. And then it could go into other stuff as it get into bleeding things like bruising and petechiae and rashes and whatnot. But where do we look for the answers? It's in the blood. And all we do is draw a simple old complete blood count, a CBC. And with that physical and with the comments from the parents, we can figure out something's going on. Well, fatigue, you know, is usually anemia. And why do we have fatigue with anemia? Well, what does a hemoglobin hematocrit do? What does it carry around? It carries around iron and it carries about oxygen to the body. And if your body doesn't have iron, which is food, and oxygen helps it breathe, it's not going to have any energy. So the lower the numbers of your H and H, the least amount of oxygen and iron can be carried around. So you're going to see a child not feeling that energetic, and you're going to see them, that lack of energy. I mean, we know that sometimes there are dietary restrictions. It could be cultural. Maybe it's, you know, they don't eat meat, vegetarians, they don't eat enough proteins or sources of iron in their diet. And this is something that will need to be investigated. We have a child who's always getting sick. Something's happening. Something's wrong with that immune system. And then, as I said, it could be something that's bleeding, which usually we see like those bruising and petechiae type stuff. Now, anemias are or is the most common sort of hematological disorder in children. And it basically is a decrease in the number of red blood cells. Decreased red blood cells is decreased oxygen and iron going through the body. You don't have iron, you don't have oxygen, guess what? You're going to have a child who is tired, right? So we do know sometimes it's a depletion of it. Sometimes it's hemoglobin, hematocrit, both. Sometimes it's the way that they're shaped, maybe the life of them or something that causes this anemia to occur. Now, one of the things is what defines anemia in a child? Well, as a child, they say less than 10. Okay. As an adult, it may be less than 11, but we get a little bit less in children. We also know that isn't that infant at about 6 months old? Remember, they don't have mommy's blood stores anymore. They have to make their own cells. Their hemoglobin hematocrit could be 8 or 9. And as long as they're not symptomatic and they're eating, gaining weight, we'll leave it alone. But again, it looked at the age there and what would be an appropriate hemoglobin for that child. Now, this is a picture right out of your book, and I think it tells you everything. So there's types of anemia, just not that iron deficient anemia. Like you as an adult say, yeah, I'm anemic. Well, that's usually iron deficiency anemia. That's the most common. It could be due to, and there's 3 classifications up top, a decreased red blood cell production, an increase of red blood cell loss, or an increase in red blood cell destruction. So you lose them, they're destroyed, or they're not produced. And that has to do with red blood cells because low red blood cells is anemia. Well, decreased red blood cell production could be nutritional. I've already mentioned that. Could be that vegetarian who's not getting all the iron they need, but it could also be nutritional deficiency of folate or B12. B12 is your intrinsic factor. It helps break down foods, right? Or it could be copper or some chronic something going on that's burning up the cells. But mostly we talk about nutrition there. Now, it also could be the bone marrow is not producing red blood cells the way it should. There's a couple reasons why. Well, there's something called aplastic anemia. We're going to go into that. And that's just, a decrease in production of your red blood cells. And we'll talk about ALL, what if you have leukemia? What's going on? Your body is eating red blood cells, and especially with all the treatment that's going through with it. Infections also eat up red blood cells, so and stop bone marrow sometimes from producing the way it should. Now, sometimes we lose blood. Well, we know if we cut ourselves and it's bleeding everywhere, that's blood loss. Well, that's an obvious. That's what usually we'll see that sometimes sparks us to go and to investigate why are they bleeding like that? Nosebleeds in children, epistaxis. Sometimes is that beginning symptom of something deeper going on in that child's body. It could be hemophilia. It could be something to do with the spleen or something called ITP, immune thrombocytopenia purpura. And we're going to go into that. It's all about platelet production. And then DIC is when the whole body turns against to each other, usually due to overwhelming sepsis and trauma. And that is something I don't go deep into in this course because many nurses taking care of children and adults with DIC have a hard time with grasping a concept. You just bleed inside all over, basically. Increased red blood cell production. Well, sickle cell disease, that is sickle cell anemia, right? And it's because the cells aren't produced normally. They're sickle shaped. And I'm going to go into all that with you. Thalassemia, sickle cells, the African American. Thalassemia is more Mediterranean Sea descendants. And then there's these weird type of diagnoses. This G6PD has to do with sugar and these children, and has to do with the bursting of their blood vessels. And then we have also the extracorporeal type things, immune, drugs, toxic, radiation, chemo, infection, all of these things increase that the red blood cells are destroyed. Now, what happens with anemia? So you get a kid who is complaining they look pale. Their lips look pale, their gums, their palms, they just look pale. And mom says that they're really have a lack of energy, and this is new. If you take your stethoscope and listen to that heart, if they're truly anemic, you're going to hear swoosh, swoosh, swoosh in there because all of the blood cells are not so tightly put together so it goes through evenly. They're sort of bouncing off of each other and causes this turbulence and it causes this murmur to occur. So swoosh, 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 instead of chikum, 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 right? That's the normal heart rate because it's all just, they're not close together. So they're banging off of each other. Now, when you're anemic, what is your body trying to do? Is trying to get oxygen to the body. And what happens is all of a sudden your heart rate gets higher, right? That heart's trying to beat, try to get that blood everywhere. And it can't because there's just not enough red blood cells, not enough oxygen to get around. So you can see if you continue to let that heart beat like that, it's going to fail. It's going to get tired. It's going to say, I'm tired of beating. I need some more oxygen in here. I need more red blood cells. And you could understand that. So what would you see? Well, you're going to see a bluer looking child, not as pink as normal. And because we know we need oxygen for part of growth and development, you're going to see a child be smaller because the body can't feed it. If you can't feed it, it's not going to grow. So you're going to see growth retardation. Now, how do we treat anemia? Well, number one, we need the history. What's going on? Why do you think your child's anemic? What are those signs and symptoms? And of course, number one, do a complete blood count. Let's just look at the numbers to start with. Now, usually, if we have a low hemoglobin hematocrit, we want to help that heart beat better and slow down and relax because it's going to be tired. So many times we will go ahead and give a transfusion. If it's hemoglobin of 6 or 7 and they're tired, absolutely, we're going to give them blood. Remember all of the things that we know about giving blood and to be watching out for that. Now, if it's due to nutrition like iron deficient anemia, well, we can change the diet, right? And if the diet doesn't work, we can always add iron into it as a supplement. We have oral stuff we can take, and we have iron dextran, which is a deep Z-track IM injection. That was the first injection I gave as a student. It was an iron injection. And I'm like, okay, so the first injection I have to give is a Z-track. And it was on a younger person. I remember she was in her 40s, and that's my first one. So I was really scared. The good thing was the lady said that it didn't hurt and I did a good job. And it didn't ooze out all over. I did it properly. So I was very happy. But iron IM is given Z-track because it stains the skin and it can burn too. Now, if we're not going to give blood yet, remember there's still volume there that still needs to be supported. So we're going to be given IV fluids because it just replaces volume, fills up the vessels basically. And we'll put them on oxygen. Now, I'm going to tell you controversially, if you don't have cells to carry oxygen, is extra oxygen going to help? It's controversial. It's better to put it on than to not. And that's what they think about it. And then minimize all of your energy expenditure. Bed rest. Have them relax. If they're not up, moving, going bonkers, running around, they're not burning oxygen. Have them relax, okay? And that can help until we can get the hemoglobin hematocrit where it should be. So as we're assessing these patients, these adults, we're assessing these children, we're going to be looking what is their background, their racial, ethnic background. As I said, sickle cell or thalassemia could become from a certain group of people and might be able to hone in on exactly what's happening here. Always the history, very important. And then we want to rule out that there's no bleeding in the GI tract because GI bleeds are another thing that can cause anemia, right? You're losing blood. Let's rule it out. So we'll do a stool for occult blood. Now, children with anemia are going to be having multiple blood tests. They might be getting multiple injections of iron or something, or even some of these conditions, multiple blood transfusions. So making sure we get that child to understand what we're doing, have them prepared, try to minimize the pain from the first time we touch that child. Because remember, these kids are anemic and you get them all worked up, angry, and scared, and like you have to hold them down because you didn't do it right. You are really burning up any energy they have in them because they don't have any reserves at all. We need to help the child relax, understand, and actually help you. Like, where do you want me to take the blood today? All right, let's numb it up. Will you help me? And I would have them put creams on, jellies on, put a glove on, put it on their finger, rub it in good. And these little things will help a child through this. And now they're a part of it. Now, iron deficient anemia, I've been mentioning it, and it has to do with not enough dietary iron. Did you ever wonder why we give iron fortified cereals and iron fortified formulas? It's because the baby's not making any of this at first, right? So we need to supplement it. We give vitamin D to breastfed babies because that helps also. Now, in premature infants, remember, they're small. They can't eat as much. So we have special formulas. We have smaller volumes with higher levels of calories. You can do a normal formula is 20 calories per ounce. We can actually do it up to 30 calories per ounce on some of these premature infants and pack in all of the nutrients they need in it, okay? So special needs, we can work with it, and there's a lot of choices for them now. Remember your adolescents, remember body image, they don't want to be too fat, they don't want to eat good, and then they're in that adolescent growth spurt where they grow 20 to 25% of their height at that point. Remember, they're not eating right. So we've got to be very careful because they're going to grab a power bar and a bottle of water and run out for the day and not eat, right? So we need to make sure they understand the importance of eating properly and getting enough iron, because without it, they're going to get tired, right? And these adolescents want to go, 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 and they can't if they don't have, their hemoglobin hematocrit aren't where they should. They're just going to be tired. There's been some cause, years ago when we didn't understand iron, and we just used to give regular whole milk, cow milk to infants. And we know now we can't do that. We need that iron fortified formula and the other stuff that we have there if they're not going to be having breast milk. We know that with iron deficient anemia, we can correct it very easily. And all that is changing their diet or putting iron in their diet. It could be a vitamin with iron, or it could be iron liquid pills. And remember, if we're doing oral iron, remember to take it with orange juice, right? Because it helps break it down. Iron has to be broke down into the stomach. If it's not broken down in the stomach, you're not going to use it. And if you don't have enough gastric juice, that orange juice will help you. Never with milk, never with food, right? Remember that. I've seen a question on the HESI regarding that, and I'm sure you're going to see it somewhere else. So giving them the iron. And if they need the injections, remember, make sure we make it as painless as we possibly can. So sickle cell, I'm sure you know someone or someone here has sickle cell anemia. You could have a trait or you could have the disease. We know that if both parents have just the trait, not necessarily the disease, every child has a 25% of having that disease. So what is sickle cell anemia? Now, I didn't really understand what all of it meant. Yeah, I know sickle-shaped cells, and I know that, your hemoglobin hematocrit are low because they die quickly. And I didn't understand much more. So me, the nerd I am, went and did a lot of research. And very simply, what I found out was in sickle cell anemia, usually something happens to create a crisis, whether stress, or an infection. Infections usually come with fevers. Fevers burn up fluid. You become slightly dehydrated. You've got these sickle-shaped cells trying to get through every little tiny capillary of the body to bring oxygen and iron and nutrition to that body part, right? Those little things get so tiny, they get hooked and they can't go down. So here we got a cell that's bifurcated, it hooked there, can't go down either one, and they back up behind it. And it swells. And now it's into the tissue, hitting the nerves. And now it's swollen, red, painful area. And distally, you're not getting oxygen, right? Because the blood cells aren't there. And this is a crisis. This could be in a knee, an elbow, a chest, an abdomen, could be in the brain, okay? So what do we have to do? Well, it's due to dehydration or very small vessels. Could be the kid out there playing sports who never hydrated, and now his vessels are real tiny, right? So we don't want it to continue with that hypoxia of that area, the death of the tissue there. We want to make sure that we dilate them and get that stuff moving again. So the factors, as I said, anything that increases the body need for oxygen can cause sickle cell. It could be usually the kid who's not drinking enough outside in the hot and sweating. Now you have decreased vessels. Trauma, crunch, makes a vessel, blood can't get through. As I said, infection, fever, stress always affects the body. And what it just does, all of those things causes a little bit of dehydration, right? Dehydration, now you have smaller vessels, blood can't get through, and it's hypoxia and cell death. Number one priority in sickle cell. And it hurts, and these kids are crying. Number one, get a bolus of normal saline in that child right now and put some heat on the area that hurts. What have I just done? I've dilated the vessel, I've created vasodilatation, and now a little bit of blood starting to get through to those areas so you don't cause cell death, tissue death because it's not getting anything there. And now you're starting to move around that clog and you're getting it moving. Now, in the other hand, I'm going to have pain medicine, but I'm going to start that bolus immediately. Number one priority is hydration, IV, and get that fluid in there. Then, of course, as I said, as we're putting the IV in, I'm have heat wherever this place is, but something for pain. We'll be drawing a bunch of lab works usually, and I've seen quite a few sickle cell crises in my career. I worked in this children's hospital ER for 10 years. And in that time, you see children come in all different places, sickle cell. And the one thing that is common is their hemoglobin and hematocrits are usually 5 and 15, 6 and 18, very low. Their cells don't last long at all, okay? So we're giving fluids, we're heat, we're giving pain. You're going to check the electrolytes because usually your electrolytes are low potassium, so you got to check it. And with that hemoglobin and hematocrit, you're always going to, on the initial, get the IV in and draw all your lab works, you're going to be drawing for a type and cross, at least a type and screen, so that you have blood ready and available. And as I said, most of the time these kids come in, 100.5 is considered a fever on these children. These children are sent home, and it's a HESI question. Biggest thing that you would be concerned about is a fever in these children immunosuppressed. They're told to get a hold of the doctor immediately, and they need to be placed on antibiotics now. They're immunosuppressed, they have no fight in them, they need antibiotics now, okay? Many children, the young ones, because they don't have an immune system yet, do they? It takes a while to build up. It's that repetition of getting all of these diseases that, anybody's immune system builds up. So they put them on actually one penicillin pill every day. It's prophylactic. And they start about 2 months. Of course, they get the liquid up to 5 years old. And that's a preventative prophylactic, and it does help. They also will be monitoring a reticulocyte count. They're making sure, is the bone marrow working? Let me look at that bone marrow. Is there something I need to do for that or not? And then, of course, as I said, blood transfusion, it will help with lack of blood flow. Because what does blood have in it? It has oxygen in it. And now we've put cells in the body which have oxygen, and it takes care of the body and it feeds the body what it needs. Now, there's no cure for sickle cell. These children, as I said, they are immunosuppressed. They are going to be having frequent infections. And that's why I say parents and children are said, you have a fever of 100.5, call the doctor. You need antibiotics now before it gets any worse, because they can't fight it. It will just get worse. And the infection, what does it do? It burns oxygen, and now it's depleting the body of cells, et cetera, et cetera. Usually bacterial infections is what kills the young kids. And we know sickle cell people can live, a pretty good life as long as they're keeping up with themselves. Now, what do we need to teach our kids with sickle cell? Especially with that one that you've seen already twice this year, the sickle cell crisis. Well, we need to tell them how to be a normal kid, how to take care of themselves. They can go out and play sports and swim and do all the things kids do, but this kid must carry a bottle of fluids with them, right? They need a bottle of water or Gatorade or Powerade or whatever they want, and they need to keep hydrated, because if they're out running around, they're sweating. You don't want to get to dehydration. It will cause a collapsed vessel. The sickle cell will get caught, and now you're in crisis. So they need to keep that fluid going, and they need to keep those vessels opening. Penicillin we're going to give, as the doctor wants it, prophylactically. And the one thing we don't really think about with sickle cell is we have blood vessels in the head. A kid with sickle cell who complains of a headache, take it seriously. It could be an impending stroke. Also, it could be in the lungs, and it could cause like pulmonary embolus type of thing. So you really need to listen to these children. Where is it? I mean, many times I've seen it in knees, elbows, hands, feet, usually joints, but there's chest syndrome, abdominal syndrome, all of these things can occur. So making sure that we keep these kids understanding from a very young age. Tell them, carry them a bottle of water around with them, okay? And make sure that they understand we need to keep your blood flowing. You're sweating, you need to replace that. Now, thalassemia is a rectangular shaped cell, very similar to sickle cell. But let's talk about what this is. This is the Mediterranean Sea, people, like I said. It's a very short life. So the spleen, the everywhere, they're producing cells. It's not a problem. But what happens is these little rectangular cells have a very short life, and then they burst. Well, what's inside a blood cell? Oxygen and iron. All this iron is going in the body, and you can actually get iron toxicity from your own blood. Okay. So there are 4 different types of them. No, you don't have to know all the names of them. Okay. We usually, when we speak about thalassemia, we think about thalassemia major, Cooley's anemia. All right. That's usually what we think about. And when we talk about it, this one is severe anemia. Your cells are bursting like crazy, and you can't maintain any hemoglobin hematocrit in your body hardly. So you must take transfusions to live, okay? So when do we find this out? When would we know? Well, at birth, the child's red blood cells look okay. And about at 6 weeks old, they start to change. And then we start to see, now you're not getting oxygen, iron, you're not getting nutrition and oxygen. What do you think you're going to see? You're going to see delays, right? And then you're going to be checking a CBC, and because the kid looks pale, no energy, right? Still the same things, but all the growth delays also. And we're going to see very low numbers, but the shape of the cell is going to be rectangular. So severe anemia, they're not growing. We're going to do it. So how do we take care of it? Well, the first thing we're going to do is get that hemoglobin level up to where it should. We're going to give some blood transfusions. And we're also going to be doing in these children, periodically, we do iron levels. Remember, I told you in the cell is oxygen and iron. Every cell spews iron out. All right. That iron in the body can become toxic, just like you drank iron. I mean, it's that serious. So, these children will be getting blood transfusions to replace the cells with the coolies, the most severe, and they also be monitoring their iron levels, and they'll either be taking a medication which takes iron, combines with it, and you urinate it out and through the urine, or they might put them on something called an apheresis machine. It's similar to dialysis, but it just pulls the iron out. It's more specific, okay? Actually, I used to run an apheresis machine, ECMO machines, apheresis machines, and it's hooked up. You pull out, you filter it, gets rid of what you don't want, and puts the good stuff back. Basically, very similar to your kidneys, takes out the urine and puts the rest in, right? So, how do we take care of these children? Well, they must be these children. Some of them are 2 times a week, some of them are once a week, sometimes they're 4 times a week. Just like with dialysis, you don't know who's going to be with what, depending on how many cells are dying and how quick they're dying. Remember, they're bursting, all right? They must be very compliant with going and getting their lab tests and getting their transfusions and chelation therapy, whether it's the oral, making sure they take it, or if they're doing the one on the machine, making sure they get it. These kids, it's going to be a hard life because there's so much time into with all of this treatment. It's going to be harder to be, quote, a normal kid, right? Because of everything that's going on here. It's hard for not only the child, it's also very difficult for this family. If you can imagine, these children are chronically getting stuck and poked, and we're getting blood transfusions. And remember, blood transfusions are not just we give them, there's always risk for them too, right? They could get these little antigens that make their blood type rough to get it. And what if their blood type is rare? So there's so many things that we must be concerned about. I mean, they can live into adulthood, but their treatment has to be done and they need to be consistent. So if you can think about it, we give them blood, their hemoglobin hematocrit's up, and then everything starts bursting and dying and it goes down. Now the heart weaks harder. It has to work harder and harder. Then you give blood and it dies off, and now the heart has to work harder. So this heart doesn't know what it's doing. So heart disease, it's overworking. It's like boom, 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 right? It doesn't know. So heart disease, big, 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 big. The other thing they decide, since these cells aren't good, let's get rid of the spleen, they might take the spleen out. But again, they're immunosuppressed, so post-splenectomy sepsis is something that can happen. And then because of all these cells and hypoxia and iron and all that, multi-organ failure is something that can happen. Maybe bone marrow transplantation is a cure, but they're not really sure yet. So aplastic anemia, this is they're not being produced. Okay, cells aren't being produced. profound depression of red blood cells. And we mostly talk about pancocytopenia, which is all of them. There's one that's just RBCs and normal white cells. But again, usually when we're tested on it, they don't say pancocytopenia, aplastic anemia, but it's usually inferred that that's what they're talking about. It's hemoglobin hematocrit are low, white cells are low, and they have a low platelet count. Oh my goodness. They have no oxygen, no iron, they have no defense against any immune things, and their platelets are so low, now they're in bleeding problems. All of those three things, aplastic anemia. This is something we treat very similar to leukemia. We give them chemotherapy. We try to burn out their immune system and then hopefully stick in a bone marrow. But it's something that, again, for life. And remember, blood transfusions, again, do we have a blood type that there's enough blood out there? Or is it one of those rare things? Because that can make the treatment a lot harder. So defects in hemostasis, this is bleeding. This means, these children, for whatever reason, they bleed. Well, the first thing we think of is hemophilia, right? You think factor VIII hemophilia. Now, hemophilia is hereditary also, and it comes from mom, the X link. It's a recessive gene, but it can happen. Now, to make blood clot, there's a lot of different things that help your blood clot, okay? We have platelets, we have factors, all of these things that we need to look at. Like, what is the thing in the body that's not working right, and why am I bleeding? Well, there are three ones that we mentioned. There's all different variations of them, but this is what we need to know. We have factor VIII. This is the most common, the classic, what you think of. You have hemophilia, it's factor VIII. But there's also a factor IX. It is just another piece of the blood that helps with clotting. And it's also called the Christmas disease. And then there's something called, and I love this name, von Willebrand disease. There was this research scientist named von Willebrand who found this little factor of blood clotting. And it also is a factor VIII. So how do you treat hemophilia? Well, number one, kids are active and they're going to go run, ride a bike, and fall down, and you really can't stop them. They still need to be children. But when they fall down and we see bleeding and stuff going on, we need to let that parents and children know what to do. Christina, did you have a question? Your hand went up.
Yes, ma'am. And this probably doesn't even matter, but why is the hemophilia B known as the Christmas disease?
Probably research scientist named Christmas.
Oh, okay.
Maybe it was found on Christmas. I really don't know. I can look that up. That's an interesting question. We try to
Professor
find out.
Bogart,
Excuse me?
Professor, did you hear me?
I didn't hear what you said.
I'm telling that my internet unstable and mostly it's not showing and I cannot hear. I don't know it's problem only with my internet or everybody.
Does everybody hear? All right. It's you. And remember, I'll always send you a recording that you can go back and listen to if you need to, okay? Or maybe you need to move to a different area. Or maybe if you're not plugged in, you're wireless, if you could plug in, okay? Yeah, she's frozen again. Okay, so hemophilia. What do you see? Well, what you're going to see is bleeding. Usually it's not necessarily a cut that bleeds forever. Children fall down, and let's say they bump and they get it on their knee. 1 second, please. I am so sorry. That was my son-in-law. I have my Christian here because he was vomiting all day yesterday. So I kept him home from school for mommy. He's with Pop Pop. Sorry. All right. So we have areas like, for instance, the knee. It falls down. Normal kids, they just rub it off, little ice, they feel better, right? Well, just like if you had some sort of orthopedic injury, you sprain your ankle, whatever, what do? You should what we call RICE. You should rest, ice, contain, and elevate. Same thing for a child with hemophilia. And it's that compression and that elevation and the ice, which is what we really need to do. I mean, it could fill those whole joint sacs up with blood, right? And it will keep going because it doesn't stop. So the problem with hemophilia and what our goal is, and the parents' goals too, is to prevent joint sac damage, right? Because it's irritating to that sac. And then they'll end up with arthritis and joint replacements and whatnot, or crippled in a wheelchair. So that hemoarthrosis, that blood in the joint, very serious. As I said, it comes from mom. And what would you see in these children? Well, if we know what type of hemophilia it is, we're going to be checking that factor 8, factor 9. Now, what other bleeding coagulopathy blood tests do we know about? Well, we know about an APTT, right? And we know a PT. So those things will also be looked at. In hemophilia, you're going to see that low level of that factor, and you're going to see prolonged PTT. It's like they had taken heparin, right? We measure heparin with a PTT. It's going to be long. Should be what, less than 40? It's going to be, 240. It's just what you see. But other stuff that work with blood clotting, platelets, we know it's going to be normal. Parathyroid hormone and fibrinogen are other two things that we look at with bleeding, but they're going to be normal also. So what do? Kids at home, the kids fell down, the knee is all swollen, you've rested, you iced it, contained it, it's elevated, but it's not going to stop. So there is home therapy. Now, many children have a mild form and just take an intranasal spray sometimes, but usually, if you have hemophilia that's aggressive, they're going to have to be given an IV infusion. Now, let me tell you a story about a little 9-year-old boy who came into the ER with his father. He literally had a knee that was all bruised on a Saturday, and he called the hematologist to see if he could, I know you got to go home. He called the hematologist and asked if he should give the infusion at home. Go ahead. I'll talk to you later. And he couldn't get a hold of the hematologist. So he came into the ER and he brought the factor with him just in case. And he spoke to our physician and said, yeah, no, you need to give it. So the father said to me, can I give it to him instead of you? And I said, if you're comfortable, can I watch? And I actually had a nurse who was in orientation. And I'm saying, let's just watch the father. Let me tell you, the way he did it was amazing. Washed his hands, he laid it out, everything was done properly, filled it in a syringe. The kid and him chose what vein to use. And all they did was a little butterfly, not a regular IV catheter, but like you use for blood draws. And he put it in. The kid actually held the butterfly there. And slowly the father pushed it in, pulled it out. The kid held pressure, put a Band-Aid on. And I was like very impressed. I mean, did it as well as I could. And and I told the father, I have not seen a parent do it as well as you did. And I told the kid how proud I was of him. Because this is lifelong, and they're going to have, and the kid might have to even do it to himself as he gets older, right? So it was very impressive. So we do give clotting factors. If they're at home, they're going to be giving them at home. That parent and that child, they did the right thing. When they're in doubt, they asked. I mean, if we could all do nasal spray, the desmopressin, that would be great, but no. So management of hemophilia, and you could see it's now not just rice, we call it price. What if your child is a toddler and you're just really being diagnosed that he has hemophilia? Toddlers are into everything, bumping into everything, hurting themselves, bruising, falling down, right? So now what you're going to do is protect that house. What about that dining room table, which is right at head high, they could bump into and cause a bruise? Now we're going to put something on the edges or change that table so that he's not going to hurt himself. Edges on coffee table are a big thing because they're always around that coffee table and hurting themselves somehow. So protecting that environment, number one, all right? And then, of course, the rest of it, the rice. Dental hygiene, careful, because soft type of toothbrushes, you don't want to create bleeding in there, and let those children absolutely know, and the parents, about making sure they get care as soon as they can, because blood in a joint can destroy the joint sac, which could create them to be in wheelchairs later on in life. Okay, so if they're doing everything they're supposed to do, they should have a pretty normal life. Yes, they've got to be careful. Blood, they need to be checked up, but do everything right. They can protect their joints and live a good life. Today, they are working on some gene therapy. It's not completely there yet, but we're pretty close. I'll see you, my dear. Take care. You see his project? Get his orange folder too there on the table. Yes, he did good. So, all right. Immune thrombocytopenia purpura, ITP. ITP, P for platelets, okay? Remember, P for platelets. Platelets are low. What's a normal platelet count? Well, at least 100,000. Children with ITP, usually, and I've actually seen a few, usually it's after some sort of upper respiratory, some infection, like a month or two before. And they come in and they're either having pronounced nosebleeds, epistaxis, or they come in and they've got this little purple petechial sort of rash on their legs, on their arms, bruising. And they're like, my kid doesn't go out and play. I don't know why he has a rash. He hasn't fallen down or anything. So, how do you think we diagnose ITP? It's a hematological condition. We're going to do a CBC. And we're going to see that platelet count, and we're going to see it probably less than 20,000. And that's going to tell you what's going on. So how do we treat it? Well, it has to be treated. We need to do something to make those platelets function more, to get it going. So the supportive is just, watching the child and the other things take care of. IV immunoglobulin, IVIG is given, boost your own immune system, and then an anti-D antibody is what we're done. Now, you get a kid in the hospital and they're telling you they have ITP. There's some things that you need to do and to monitor to take care of that child. Well, number one, you're going to be teaching all about bleeding and being careful with that, right? And signs and symptoms and when to tell mom about things. You're not going to stick this kid with a needle needlessly at all. You're going to avoid it. Many times they'll put an IV in so that they have an access. They can draw labs and whatnot through that, so you don't have to keep sticking that kid. You're going to be monitored for bleeding. Where are you going to monitor? Well, let's look at the gums. Let's look at urine. Let's look at stool, right? We're going to be checking that body for bruising. Absolutely. Of course, monitoring those blood counts. And then sometimes with the IVIG anti-D, they might give corticosteroids. So care management is no sticks that you don't have to do at all. Watch them, monitor the counts, and maybe steroids. Now, epistaxis. This was a HESI question last quarter. And epistaxis is a simple nosebleed. And we know that a nosebleed once we don't worry about. But if we see more than one going on close together, we're going to go searching why. And what do? A CBC, right? So we do it first and we'll look at it. Now, a child especially young kid, they're bleeding out of their nose. Oh my God, I'm gonna die. Get me a Band-Aid. They're freaking out, running all over. Their heart rate's going. They're nervous. And what you're doing is you are making that child bleed more, aren't you? So, number one, keep them calm. What you do is take your thumb and your finger and put it on the bridge of their nose, hold it tight for 10 minutes. You're going to lean them forward a little bit. And why forward? You want the blood to come out of the mouth. You don't want it to go down to swallow. What's going to happen? They'll vomit, and that could reopen what's bleeding there. If after 10 minutes you take your fingers off and it's still bleeding, they need to go get emergent care. Call their doctor, get to the ER. Maybe it needs some sort of other treatment done. Okay. So epistaxis was also one of your NCLEX questions. HIV/AIDS. Well, you think, well, this isn't usually till later on in life, but what about that newborn born of a mother with HIV/AIDS? It happens. Now, at the PPAC that I did clinicals at, they had triplets born of a mother with HIV. One had AIDS, one had HIV, and one had nothing. And why? They all had the same treatment. It's just, what did we do? Well, what we do with HIV/AIDS in a mother, which is born to, and you have this newborn, our number one goal is to improve that newborn's immune function. If that mother could and knew to get this heart treatment, which is an highly active antiretroviral therapy. It's like giving a viral medication to stop a virus. Usually we start about at 22 weeks, and then we will continue these antiviral therapy after birth. And as I said, some children will turn around. Now, the other crazy thing I have seen that when I first started working in the newborn intensive care unit was children born positive HIV can zero convert after a year, and they'll be zero. They'll have no HIV if given the proper medications and treatments. So it doesn't always mean forever and ever they will be. And today it's universal precautions. So as nurses, we don't need these signs above the bed like they did back in the 80s. I mean, back in the 80s, when they first found HIV, there was signs everywhere. And we know HIPAA today doesn't allow stuff like that. So again, newborns, big thing, improve their immune function. Now, respiratory-wise, the biggest most common opportunistic infection is PCP pneumonia, pneumocystic cardiac pneumonia, and that's the most common respiratory. They also can get things like yeast, and a lot of these things we do preventative care for them. So our goal again with this is education, especially letting any pregnant woman know. Sometimes they don't know, they don't have education. I mean, adolescents, well, now they could go and contact. Knowing about safe sex, things like that is important. We think adolescents realize, but they don't always know. And again, HIV can hurt, so it is pain management. And then if these are adolescents, they are going to feel less than. So there's a lot of psychosocial needs needed for that. So treatment, hematological, immunologic disorders. Well, we know we're going to be doing a CBC. We're going to find out what they need. Do they need blood cells? Do they need platelets? And if they're giving any sort of blood product, make sure that we're always alert to proper protocol for administering, and you follow what has been said. Where I worked is you did a set of vital signs before. You checked with another nurse all the information. You signed for each other. And then 15 minutes later, you take another set of vital signs. What do you see with a reaction to blood? I mean, many times it was simple as a fever. They were 98 and now they're 100.8 in 15 minutes. That is significant after the start. Sometimes it's rash. Sometimes you'll see some air emboluses, or you'll see volume things with, difficulty breathing. But most of the time, it's just a fever. So, what do you do with children who's had that uh, reaction? Make sure that that bag of blood goes properly in a properly labeled, bag back down to blood bank to be looked at. Okay. Apheresis, I mentioned it. It pulls out what you don't want. Is it the iron? Like I said, we could do that. And then bone marrows. We do bone marrows to look at the way blood cells are being formed. What do they look like? Now, children, there is, if you've ever or have opportunity to see one, they could do it in the sternum. A lot of times, children, they'll do it on the iliac crest and the hip bone because they don't want them to see it. But there's a sound that you will hear, and that can scare a child. I know the first time I saw it, I was like, ooh, that sound does make you ponder. Does the patient hear this? Does the client know what's going on? But with children, we do usually medicate them, give them something to calm them. We use numbing on the outside, and now we're numbing inside the tissue too to try to decrease the amount of pain. And the one thing, especially children, which might have ongoing bone marrow aspirations, let them know that it can hurt a little, but you're going to do everything so that it will hurt as little as possible. And tell them why. And it's so important to get what that blood is showing you. And kids will work with you, but be honest, always be honest. So when a parent has a sickle cell trait, both of them do, what's the chance for each child will have sickle cell anemia? $25, $50, $75, or 100%?
50,
25?
It is.
50,
It's 25%.
25.
25% if they both have it. Yes. All right, some neoplastic disorders, blood, it's leukemia, right? We're talking blood. So leukemia, lymphomas, we're talking white blood cells, right? There are problems with cancer with that, and you've all heard of them. Leukemia is the white blood cells. Peak onset for children is ages 2 to 5. And it's more in boys less than a year old. And today we've got great survival, but it is a treatment. It is scary and it's intensive. Okay. These parents need a lot of hugs. Of course, your children do, but parents are going through a lot. Now, what is leukemia? And this is the definition. I put it in big red. It's unrestricted proliferation of immature white blood cells in the blood forming tissue. So your white blood cells are immature. What do white blood cells do? They fight infection. If they're immature, can they fight infection? No. So this is a child who can die from overwhelming sepsis extremely easy. Okay. So how do we evaluate blood? Number one, a CBC, right? Again, a CBC. What they also do is a smear. And just like sickle cell, thalassemia, they're looking at what the cells look like. We're looking at what do those white blood cells look like. And you're going to see immature leukocytes, okay? And you're going to see really low counts. Now, what numbers would you see? White cells are 5 to 7, 5 to 10. I mean, if you have an infection over 15, I would say would be a nice infection going on. Well, in leukemia, it could be 0.1. that means there's 100 white blood cells, right? That's nothing, absolutely nothing. So there's nothing to fight nothing there. So you would see very, very low numbers in it. So between looking at immature white blood cells, seeing the low number, then we're going to be doing a lumbar puncture. Be prepared, it's going to be happening next. We want to make sure, is it in the spinal column and in the central nervous system? Again, this is a procedure where they stick a needle into your spine and it can hurt. Again, make sure you're honest with this child. Now, I have done, many a lumbar puncture, and I make it into fun. And I tell them you're going to feel touch. You might feel some discomfort, but I'm going to give you the biggest, nicest hug you've ever had. And I put my arm around their head and their knees, and I hold them up on their side. And I'm saying, so tell me, is that a nice hug? And then I have usually child life blowing bubble, well, not blowing bubbles at this point, having an iPad showing them some sort of cartoon or something. And now they've forgotten about what's going on and that kid's not moving. And again, I made it into a game. So now we say, okay, we have leukemia. Yes, we've checked everything out. Now we're going to start chemotherapy. Now, induction therapy is the first thing we do. It's the first 4 to 6 weeks of chemo. And we hit them with everything because we want them literally to look like they're in remission after 6 weeks. It could be 1, 2, 3, 4 chemos, depending on the cell, depending on the physician. And we want to eradicate everything, wipe it out. But it doesn't mean all the cells are gone, right? They're sneaky, they hide. So we're going to put it intrathecally, we're going to put it into the central nervous system, and then we're going to do consolidation therapy. And that's just to make sure that they're gone. And then, we'll do that for a while, and then we'll put them on maintenance, usually up to like a year afterwards. Usually it's just a pill a day, again, just to make sure it's gone. So induction retrieve is going to be achieving your remission. Now, many times leukemia, a stem cell transplant can work. Well, if we have their umbilical cord blood, that's it. We know what we can give. So there is autologous and there's allogenic, and which is what and why. Well, auto is automatically mine's the best. Auto is automatically mine's the best. Allogenic is all others. Okay? That's how I remember the difference. What is the difference in, which is better? Well, you don't need to be matched as in blood type. This isn't like a blood transfusion. They say, yes, your sibling is the best of an allogenic, all the other people, but it doesn't have to be. If you have yours, automatically, it's a no-brainer. It's going to be the best one that we can give. So it can be anybody that can give it. Usually parents try to pick the one that's from a family, just because they think it will be the best. Now, the one problem with these things, there can be that rejection with it. And it's graft versus host. And because it's given into the body, you can have symptoms anywhere in the body, and it could cause severe organ damage. It's really a scary thing to do, but if you have leukemia and chemo's not taking care of it, can't get rid of it, you have to do the stem cell transplant. So taking care of these children, remember, always prepare the kids. Be honest, let them know what's happening. Using dolls, let them touch equipment. They're most likely going to get a port put in them, which is like a Broviac, a central line, but it's underneath the skin. And every time they see something and they need to get blood drawn, they just put their numbing cream on there and get it ready for the doctor or to the lab or whoever is going to be drawing it. So they can hurt. Make sure any pain that we address it. And again, these children don't have a white count. We have to protect them from infection. Hand washing, hand washing, hand washing, right? And wearing a mask if you're not feeling well, or give it to somebody else to take care of for the day. Our complications are infection. The other thing is hemorrhage, because we're losing blood components, your hemoglobin, your hematocrit, and your platelets, and you will be getting blood products during this whole thing also, because chemo just doesn't kill the bad white blood cells. It kills a little bit of everything, okay? And then, of course, you're anemic, and we know with anemia, this child's going to be tired, and this kid is going, need time to do things. One of the things is to be very careful with those therapeutic agents. Now, one of the things about working children and chemo, this is one of those areas that many nurses don't want to work. It's emotional. It's very emotional. And it is one of the highly sought after things to work. They want these type of nurses, and they'll pay them all sorts of sign-on bonuses. I think the last one I saw was $25,000 for a 2-year commitment just to sign on, working it. What I say about working with an area where, a lot of children die, remember, it's not that a child died. What did you do for the child and the family when they were alive? Did you make their experience as best as you could? I have parents today still reaching out to me on my birthday and on like Nurses Week, children that have died, parents reaching out, telling me, you were Chris's favorite nurse. You were Olivia's favorite nurse. I hope you're having a good day. You can make a huge difference. Yes, I cry. Yes, I cry with the parents, and we cry together. They become my children when they're in the hospital with me. So prognosis for leukemia. Well, what was that white count when you got them? Was it 0.1 or was it 1.0? That's what I mean. Do you have any immune system? How old were they? And was it the ALL lymphocytic or myelolytic AML cell? AML is harder to cure than an ALL. Are you a boy or are you a girl? And what blood type are you? Are you that really hard one, to get blood? So more cancers. Well, how do we treat cancer? Well, we do chemo, we do radiation, we do surgery, we do some of it, do all of it, or we do part of it, okay? They're all different according to what are you treating here. The one thing with cancer is they're doing a lot of certification courses that nurses must go through in order to be able to do this type of nursing. We know that our goal is to have that kid found out early and to try to put them in remission and cure them, right? That's our goal. So what do you see? I had a next door neighbor who went to the ER complaining of being tired, having knee pain, bruising and petechiae, and she was pale. She went to the ER because she felt so horrible, and they found out she had ALL. So what did she see? Oh, and she had a fever too. So she had pain, fever, ecchymosis, petechiae, bleeding, and she was tired. And she was anemic. She had a 0.1 WBC count on admission to the ER. Today, she is a PhD from University of Miami in psychology. So she's okay. She lived through it and she did well, but it was a heck of a treatment to get her there. But you see pain, fever, bruising, petechiae, weight loss, lethargy, absolutely common when you see it. Now, one of the things of treating these children, we're just wiping out immune systems with all this chemo and radiation, right? So we have to be understanding about which child, let's say you're on the oncology floor and you've got 3 children, let's say you have as your assignment today. It's like, which one do I see first and why do I see them? Well, we're going to be most concerned with these children about immune system, and how susceptible are they at getting sicker and how quick? Because a low immune system, put a fever on top, they could go into sepsis and die by the end of a shift. That's how serious it is. So what we look at is neutrophils. What are neutrophils? Neutrophils are white blood cells, right? They say if an absolute neutrophil count is 500 or lower, this is your emergency child. Normal should be above 2,000 about, okay? So there's a little bit of a difference there. So if you were given a scenario of what child are you going to see first? A child with a neutrophil count of 500 with a fever of 100.8. That is your priority, right? A kid vomiting with a fever, oh, whatever, diarrhea or this, kid with that low neutrophil count is your priority. Now, if we're seeing this, we know that something's going on somewhere and we need to find out where this infection is coming from. That's the fever, right? Where's that fever coming from? Younger kids can't tell you. Older kids can say, oh, my throat hurts. But you're going to look at urine. You're going to look at blood. You're going to look at spinal fluid. You're going to be checking sputum and mucus. All of these things, I want to know, where is that infection come from? Once we collect everything, we usually just start them on a broad spectrum antibiotic. And we don't start out with amoxicillin, not in cancers. No, we're going to go right to vancomycin, as we call the big guns. We need it strong and we need to get it quick because these children, adults also, can go into septic shock extremely quick, okay? So treating infections your priority and preventing infection is priority. Another thing is we're burning up platelets with this treatment. Again, platelets aid in clotting, which prevent bleeding. You don't have platelets, there's going to be bleeding. So now you're having an infection and now you could be bleeding. So we need to make sure that doesn't happen. Now, you can give just a platelet infusion. You don't have to give a whole unit of blood. They actually take all the cells out, just platelets. Remember the apheresis machine? Well, they do that to separate bloods. You can have plasma, you can have platelets, you can have packed cells or whole blood. There's all different ways that we can give it. So we will be given platelet infusions to those children whose platelets are low. Remember, we've got to be careful. Any child receiving lots of blood, we're worried about them creating these new, as I said, antigens that make it difficult to find blood in the future. Also, a child who's going under this treatment, although we want kids to be kids, we don't want them where they can fall down and hurt themselves and scrape and now create an open area for infection and for bleeding, okay? They can't during this time. They have to be quieter. Remember that induction, the first 4 to 6 weeks that we're there, for remission? Anemia happens. Not only are they killing those bad white blood cells, they're also, and cancers, they're also killing the hemoglobin and hematocrit, okay? Again, with anemia, they're going to be tired, so there are going to be limits on them. Years ago, we didn't treat vomiting until they vomited. How stupid was that, right? They're going to vomit. We know they're gonna. So I used to say, yeah, they vomited it, and I would give it early. Well, that was sort of lying, but it actually helped these patients not vomit, right? Today, if we're giving therapy, chemotherapy, we're going to medicate them before we start. We're going to do everything to prevent them from vomiting, okay? They're using synthetic cannabinoids now. You know, I've seen bunches of documentaries on it used for things like seizures and use in cancer for that nausea, to have HIV to promote appetites. I mean, it can be used in conjunction with medical care as long as they both sides know what's going on. You don't have to hide the use of it today. Altered nutrition. Well, why wouldn't they want to eat? I mean, right? But they do. What if their mouth is all swollen with sores and stuff? It can happen. So we need to monitor nutrition. The easiest way to monitor it is daily weights, right? Are they growing the way that they should? If they are, they're eating. If they're losing weight, we know it because just simple as a daily weight. I mean, what do we do every visit? As I said this over again, and you're going to hear it again. Every visit on a child, we're going to do a height and a weight, aren't we? And that's to monitor. Are they getting where they should be? Is their growth where they should? And if not, why? And we can catch it pretty quick instead of waiting till, oh, well, when was our last weight we did? Oh, that was 3 years ago. Well, you can't correlate that to nothing. We think that high protein, high calorie, full fat, because they could take smaller amounts and they could get the nutrition out of it. And that's why. As I said, mucosal irritations happen. Make sure that we don't give them foods that will hurt them. And they don't like you to give that numbing lidocaine. They do have something called viscous lidocaine, but it's numbing. And what if it goes in the back of the throat, numbs the back of your throat? You can aspirate. So they don't recommend it. So things like, and mucosals from mouth to anus, anywhere in between, could hurt. So again, watching your diet. If it's, the anus that's irritating, there's always sitting in that nice warm bath that can help. And the mouth, we could just vary a nice mouthwash sometimes help. But it's hard to work with mucosal ulcerations. Another thing with treatment is these kids are in pain, right? They're not eating well, right? So they're going to be constipated. What happens if they're pushing down when they're constipated? They can cause strokes. So we have to be very aware of that. So making sure that stool softeners are used so that we don't have them bearing down, causing a possibility of neurological side effects, okay? Also making sure that, for instance, if they have pain in their jaw, again, making sure they get that medication they need. If they feel better, they're going to eat more, right? And if it's giving them something for pain before they eat, go for it, give it. They also can have blood in their urine, so of course you're going to be watching for it. And they should be drinking fluids, whatever fluid they like, let them drink it. Alopecia, probably one of the most common things. One of the things that I did, so I go to whatever store, Walmart, and they got these little spools of little ribbons, all different colors. And I would make headbands and bows, and I would wear one for the day, and my girls would wear them. And I did this even in the cardiac area. You can do it in any area. And it made them feel better that they were matching their nurse for the day. I would even send one home for their sister or their cousin if they wanted, because again, taking it away from, I have no hair, to, oh, look at my pretty bow, my nurse made it. Look, she has one too. There's things you can do. I've had brothers and fathers shave their hair off. As nurses, we're not going to shave our hair off, but we can have those pretty little bows. They were 99 cents a spool. I had like 10 or 20 of them, and we had a lot of fun with it. And many times these kids are on steroids, and that's Cushing's syndrome. Older kids get very self-conscious about all this pudgy stuff. So making sure this kid has clothes that aren't tight, at least they can hide it. I mean, how about if we wear a tight shirt, we feel like we got a little tummy roll, we're pulling and we're pushing it around, right? To make sure nobody sees that roll. Well, kids are the same. They're absolutely the same. Make sure that, and tell the parents, did you get the next size up of jammies? That she is feeling uncomfortable. Again, getting them ready for procedures. Many of the times, yes, they are sedated. Not all of them are. So let them know what's going on. Always use topical anesthetics. And again, encourage the physician here. Here's a 2% for deep down lidocaine, for whatever those like bone marrows are. Pain management, make sure they're getting it around the clock. Don't make this kid cry before you give it because it's not going to work. There's this smaller doses around the clock work better than big doses occasionally. So making sure they have enough so that they can at least not be in pain. Now, there's two types of lymphomas. There's Hodgkin's and non-Hodgkin's. And you're going to see a question. Hodgkin's and non-Hodgkin's. So Hodgkin's is lymph nodes with metastasis to the spleen, liver, bone marrow, lungs, and tissues. Now, Hodgkin's is these big, from the shoulders up, big lymph nodes. And you could play with them, pat on them, they don't hurt. And it's usually this big lump in the neck, excuse me, or under the arm that brings the parents into the doctor. They're like, something's not right here, right? So they bring them in. As it gets swollen, it occludes the airway. So that's the cough. And then it gets to the anorexia because it hurts now, just swallowing, not that lymph node. And then it goes fever, anorexia, weight loss, and night sweats. Now, how do we look at it? How do we treat it? Painless enlarged from the shoulders up lymph nodes, all right? We'll do that history, always a CBC we're going to be looking at, and other inflammatory factors, the C-reactive protein or SED rate. That's the CRP and the SED rate. And the other one also look at that. And what they'll do is a lymph node biopsy. And when they do the biopsy on these big things, they'll see Sternberg-Reed cells. Now we know it's Hodgkin's. Hodgkin's are those big cells, those big nodes. And what they'll do is they'll do radiation, try to shrink it. And they'll put marks on the skin. Don't ever wash them off. What you should do is at the end, when they're no more, you have a party and you wash it off and you say goodbye to the purple marks they have on you. And that makes it fun for the kids, something to look forward to. You got to do creative stuff. These kids, it is hard to go through these treatments. So you do radiation, you do chemo, and sometimes they have to remove it, but usually that will work there. Again, you're preparing them, they're aware of what's going on. And the problem with radiation, chemo, there is a risk for infertility, always, always in the future. Now, Hodgkin's, a node you can see, painless. Non-Hodgkin's are lymph nodes, but you don't see them. They're diffuse, tiny itsy-bitsy nodes all over. So, I got a question. What is a diffuse type of lymphoma? Poor differentiated, diffuse, non-Hodgkin's. What is the one? Painless enlarged, and that's going to be Hodgkin's, okay? Again, we treat it just about the same. A lot of times these things also can metastasize. We treat it something like your leukemia again, and they'll do a biopsy, but they have to go in a little bit more because it's hard to find them because they're tiny, itsy bitsy. And this one we'll do a bone marrow on. Again, radiation, chemo, going through induction, with our goal of remission. And then remember, chemotherapy and everything with it, we need to be concerned, making sure that, the ulcers, the hematuria, vomiting, all of these things that we're addressing. And now brain tumors. Brain tumors, most common of solid tumors are brain tumors in children. Doesn't mean that they are malignant. They could be benign, but they're occupying space and pushing pressure. and they're creating some sort of deficit somewhere. How do we treat it? Well, you have a tumor in the brain occupying space. You want to take out the least amount of tissue that you can, because you don't want to take out memory or speech, right? Or hearing or some other thing that the brain does. So we're going to do radiotherapy, radiation, let's get it smaller, chemotherapy, make it smaller, and then do surgery to take it out. We want it shrunk as far down as we possibly can, and then we can take it out. These parents need to be prepared for what these children are going to look like. Can you imagine waking up and seeing a kid with this big dressing? Usually, of course, there's a dressing first. When they take it off, having these big suture lines all over, it can be very scary. Preparing the family, preparing them, they know what's going on. Another thing with nursing is we need now to know how to take care of that kid. And what do I mean by that? Well, there was a space where that tumor occupied that now it's gone. Do we lay that child on that side or on the other side, or do they have to be straight up? Is the brain going to push somewhere where it shouldn't? Is that going to create issues? Positioning is huge. Elevate the head of the bed, don't elevate the head of the bed, okay? Can they cough? Can they not cough? All of these things are very described in the post-operative orders of these neurosurgeons. Another thing so important is fluid. You do not want to give too little or too much fluid to these children. Too little will make it dehydrated and put more mobility in the brain. Too much is causing more pressure in the brain. So again, intake, output, daily weight. And you can weigh children in beds, right? Very important that we monitor fluid balance on these children. Another thing, of course, is, pain control, comfort. And in the end, some of these kids need therapies to get them back to where they started from, physical, speech, occupation. But all of these things can be started and looked at. And of course, these kids, we want them to be what they were before, if absolutely possible. Now, a neuroblastoma is a tumor that grows in the belly. It gets big, so it starts on one side, then it encompasses the whole abdomen, but it goes to the brain. And usually we don't see it until we see like an eyeball getting swollen or ecchymotic area there, or we're seeing some sort of neurological symptom like paralysis. It is rare, just rare. It is the tumor, usually by the time we want, it starts in the belly, as I said, it's already metastasized by the time we know it. So outcomes are not where we really want them to be. Okay, this is a difficult tumor to get through. Children can go through it, but many of the outcomes aren't good. Now, osteosarcoma, cancer of the bone. This is a cancer. I love watching documentaries on medical stuff. I'm one of those people. And there was a football player who had to work really hard to get into college. It was a walk-on, had to prove himself. Then he ended up being like the one who put out 100,000% and ended up making the team, et cetera, et cetera. And in one of his last games, the last season, he started complaining of pain around his knee and he was limping. And he just kept going, going, going. And I think on the last game, it ended up, he was in so much pain, he had to go off the field. They brought him to the hospital. And what they found is he had a bone cancer. Usually, what you'll see, of course, is the pain. You'll see the swelling. And younger children, you'll see them limping. These are usually adolescents. What you'll see is anemic, right? It's a cancer. They'll start getting anemic. Then, of course, they're getting tired. With the anemia comes the infections and weight loss. And the first thing we're going to do is an X-ray, and we're going to see a fuzz on the X-ray. And then, of course, we'll do CT, the CAT scan, MRI, and go for a biopsy. Well, the entire bone has to be removed. Most of the time, this is on your femur. So that whole femur bone has to go away. You can't just cut a little piece off. No, the whole femur bone connected to the hip down to the knee has to go. What they tried to do is salvage the lower part of the leg from the knee down. And look at that picture to the left. They take the lower leg, turn it around, and hook it back into the hip. And why do they do that? Were they going to place a prosthesis, right? So that is the goal. Many of the time it's a pure amputation, but there is nothing there to hook a prosthesis on more comfortably than trying to salvage it. You know, they tried to do chemo and whatnot on these kids, but they have to do surgery. They have to get rid of it. Hopefully, we can salvage it, and then through therapy, we can get at least them up and walking. These are adolescents. Body image, can you imagine? Now, Wilms tumor is a kidney tumor. I've seen one in my lifetime. And when I saw the kid, I knew what it was when I did my assessment. During the Haitian earthquake in Haiti, we went down as the hospital to help. We saw this child that had this tumor in its belly, and through religious organizations got him up here. I didn't know anything about it. I'm in the ER, I'm working triage. These people bring this child to me and this pack of papers, all in French, I don't speak French, and told me I was told to bring him here for admission. And I said, for what? And they said, I don't know. Here's the pack of paper. I'm like, okay, I don't speak French. So what did I do? I did an assessment, right? So I got on the kid's level, gave him a sticker. I showed him. Now he speaks only French. Showed him the stuff. I was able to get a whole assessment done. As I was looking at his abdomen, listening, that the left lower quadrant had a softball hard tumor. And for some reason, I knew it was a Wilms tumor. So I immediately told the charge nurse and the charge doctor, I think this is a Wilms tumor. And we brought him in, put him in a room, and said, anybody here speak French? You always have somebody in your department that'll speak French here in Miami. So we got somebody who could speak to him. We did find out. We did a X-ray. We did a CAT scan. Prefer not to do an ultrasound on these kids because the problem with these tumors, they're encapsulated. And if you break that capsule, little micro pieces of metastasis will go through the abdominal cavity. Now it's metastasized. You can't touch this abdomen because little pieces will break off. You do not do a biopsy before surgery because you've opened it up now, and now the metastasis is going into your abdominal cavity, right? So this is a case where they did surgery. They didn't prefer to do radiation or chemo on this kid first. They went and did surgery. Now, above the bed, on the chart, below the bed, do not palpate abdomen, okay? And the kid was 3. So, and it's African-American boys. This is what you see a lot of them in. And we put there, do not palpate abdomens. When you're changing the diaper, you had to be very careful, not to touch, not to have it too tight, right? So bathing, changing, whatever, we had to be careful with. Now, when they do surgery on this child, remember there's no biopsy because we're not going to put the cancer in that tummy. If you look at that incision, they open up that abdomen. The kidneys are in the back, way in the back. So now they've manipulated all the bowels. Now they have taken the tumor off, manipulated kidneys. Post-operatively, you need to be very careful with monitoring bowels and monitoring urine output. This kid did well. This kid went back to Haiti, and somehow we got a letter back to the nurses on the floor where he was to say that he was doing great and to tell us thank you. So it is curable, but it's something that I won't forget. This little boy who came to me, and I was able to figure it out because I followed him closely. Rhabdomyosarcoma, so that's in the muscles somewhere. In the eyes, the ears, the nose, the mouth, these are tumors that are there, again, that we have to remove. Retinoblastoma. Ever open your back door, turn the light on, and there is a dog, a cat, a deer, a bear, or something, you see shiny eyeballs? That's what you see when you put a light on a child with a retinoblastoma. It's this whitish glow. It's also called cat's eye, is one of the other nicknames for it. And when you put the light, it doesn't respond. All you see is like that old flashes you used to take the cameras, that the eyes used to always be white. So again, radiation, leave that little blue mark alone. Don't ever wash it off till the end. They do chemo, and then they usually will take the eye out. The whole thing has to come out. And once they take it out, many children as they get older are very conscious about it, and they could put in fake eyeballs. I didn't realize probably what it was until I started teaching. I had this kid in high school who used to take his eyeball out and roll it around the desk just to gross all the girls out. And then he'd put it in his mouth and lube it up and put it back in his head. And I was like, oh my God. And I'm sure it was a retinoblastoma. But these kids do well. Get it out. They'll just have vision out of one eye, but usually they do well. Again, make sure, that these children are prepared, those purple marks, etc. But through the treatment, they're okay. Now, germ cell tumors. Let's talk about testicles. Let's talk about monthly self-exams. Women do breast. Men should, check their testicles, seeing if there's any lumps in there. Had an 18-year-old boy come in complaining of testicular pain. I was in the room with another nurse, and I heard her say, okay, drop your pants. She put on gloves, and one of the testicles was huge. So the kid goes to the back, and they do a urine, they do a testicular ultrasound, and then they do a chest x-ray. This child already had metastasis to his lungs and to his kidneys, et cetera, et cetera. It metastasized that quick. He said he just saw it. It had to have been there for a while. Number one, to be that big, but the kid was 18 years old and had testicular cancer. Liver cancers. You think, wow, that's the big thing. Well, livers have lobes. Take out the lobe and you actually do really well. They regenerate, don't they? And survival rate today, I have watched such miracles occur. This is 80%. I'm sure when this book written was 80, it's probably 90% today. So many things and changes have been done. They're aware of it better. There's more availability, more insurance out there, especially for children than there ever was before. So cancer rate has gone better. On Facebook, when you see these little signs of these kids cancer free, I always smile because I've been involved with, I can't tell you how many kids, and doing walkathons and raising monies and all sorts of kids. So cancer's better than it ever was, but we're not done with it yet. Any questions? I think we went far. I think we did it good. I have a 50-question Kahoots. We're not going to get to it today. I will send it to you. How does that sound? All right. I'm not going to sit here and make you go to 6 o'clock. You've got things to do and your time is precious. Remember, Kahoots are very, very important. Your concepts from exams are on the Kahoots, so make sure you go over them. And before any exam, go through your Kahoots. You will find you understood that concept. You can use it in any way, upside, backwards, and forward. And that's what those Kahoots are for. I work hard on them for you to make sure that you have all the concepts you need, to be successful. So, any questions for anybody? Thank you, everyone. You have a great evening. Take
Thank
care.
you.
My
Thank you.
pleasure.